So the management of bleeding in patients who are taking DOACs is a real problem, and one of the big issues we run into is how do you determine how much of if the drug is present and how much is present. And people talk a lot about doing levels and this, but in reality, hospitals are never going to have the capacity to rapidly test for the presence of 10A inhibitors. Same as in the preoperative setting. You have a person who needs emergency surgery. Hospitals just aren't ever going to have the capacity to do that testing quickly. So the availability of a rapid test, qualitative or quantitative, would be immensely helpful. And realistically, I think the only way we're going to get rapid turnaround tests is if they're qualitative. A urine dipstick test like this one would be very, very helpful, both to guide the care of patients, but also to provide clinicians with reassurance about the level of the drugs. This will become even more important when we have antidotes available to us, because they're going to be very expensive. And hospitals will only want us to use them in patients in whom we know the drug is present. We saw today the presentation of the results of the ISTH study, where a significant fraction of the patients didn't have any dabigatran on board at all when they actually received the ISTH. And that'll be a real issue for andexanet, because apixaban and rivaroxaban are even harder to detect using standard lab tests than is dabigatran. Right, so obviously if we're using it as a screening test, we want to make sure that it is sensitive, it has few false negatives. The specificity is probably a little bit less important, but obviously you'd like it to be as high as it can be. But the important thing is when it says there's drug present, but more importantly, when it says there's no drug present, there is no drug present. So sensitivity is the real issue.